Thank you for inviting for excellent topics. So we'll talk about what's happening in last 1 year or so, what's happening new. Um, I've divided this presentation into two. One is an early ovarian cancer and second is a late recurrent ovarian cancer. So what has happened in precision medicine in early ovarian cancer? I think there are three, I think major article, but I've gone on for two major article. One is can we give more bevacizumab than GOG 218 has given? Although there is a clear question that whether we should give bevacizumab uh, uh, or not. Then there is a upfront data set on Solo 1, which is more than a 5-year data set. So let's talk about the boost trial data set, which is more bevacizumab. The one shown in reddish color is what I would not say I've been giving, but many people would give bevacizumab for 15 months. And based on the fact that the PFS started to come closer when the bevacizumab was being stopped and the benefit of BFS was modest and the OS was not there. So Germans thought that if we give more bevacizumab, we can possibly continue to keep on separating the PFS and we may get even overall survival benefit. But that's a lot of bevacizumab. For the safety, because we obviously are scared about the toxicity of bevacizumab. There was no major difference between BEV 15 months and BEV 30 months. There was no major increase, or there was in fact no increase in intestinal toxicity. I think these are two major primary endpoints. One was a progression-free survival and a secondary endpoint of overall survival. If you look at BEV 15 with 24 months and a BEV 30 with 26 months, you could see that not giving more bevacizumab does not change the PFS curves. And you look at PFS in one way or the other, it does not impact the PFS. The most important endpoint would be an overall survival, although numerically better, not when it is used by restricted means, but you can see that there is no improvement in overall survival. So I think that a small debate about we should have given a more amount of bevacizumab stands close today, and there's no role of giving more bevacizumab than so-called standard of care. So Solo 1 is the use of olaparib, and we all have been using whenever the patient can possibly afford this extremely costly drug, but it has been now the standard of care. So the data set of Solo 1, which is a 5-year follow-up, was actually eagerly awaited. The aim of this 5-year follow-up was to see PFS with some clinical risk group and to see what is the long-term efficacy and tolerability. So this curve largely explains what is going on. This is the point at 24 months when the olaparib was stopped, and you can see there's a 30% incremental benefit. You stop olaparib here and still approximately 30% incremental benefit is there. That means stopping olaparib for a long period of time also does not impact on benefit, and there is more than doubling of people without the disease at 48%. And you can actually see some flattening of curve in both the groups, both the placebo group and the olaparib group. Maybe we have much more cure rate from 21% to 48%, and the difference in PFS is an extremely good 42.2 months. So I think this is the robust data of PFS from the adjuvant or a maintenance first line use of olaparib. They defined stage 3 into high risk population and low risk population. Assumption was that if you have a low risk population, you may not have that much of benefit with olaparib, so you may be able to limit olaparib to high risk subgroup, but that's not true. Low risk group does better than high risk group, but the quantum of difference between the two groups is more or less the same, 0.38 and 0.35. So one would not be able to not offer olaparib to either a low risk subgroup among stage 3 or just to give only to high risk subgroup. Obviously the cost is a major issue. All such patients who are eligible for olaparib benefit equally. There was no incremental toxicity. Most importantly, MDS and AML were no longer more reported. The incidence was 1.5% or less than 1.5%. So what has happened in last 1 year in ovarian carcinoma? Giving more bevacizumab? Absolutely no. Can we be more comfortable about using 2 years of olaparib or more depending on residual disease? Yes, we can be. Are we possibly curing the patient? Yes, at 60 months, 41%, for near 48% of data seems to suggest that we possibly land up with double the cure rates. Possibly too early to, it's still early to say, but yes. In the relapsed ovarian cancer cases, a lot of data has happened. There is a Solo 2 final data. There is a NOVA and NORA data upset. Extremely exciting combination of PARP inhibitor and anti-angiogenesis drug, non-chemotherapy options. There is prognostic evaluation of HRD versus loss of heterozygosity, Is HRD a prognostic factor? If your patient has done extremely well with PARP inhibitor, can we re-challenge PARP inhibitor? If there's an extreme late relapses in germline BRC, do we need to give them chemotherapy, both resistant and sensitive cases? Can we get away with single agent PARP inhibitor? In fact, rucaparib and olaparib is approved for that. And what exactly is the role of immunotherapy alone or in combination with other drugs? Solo 2, like Solo 1, has been reported for a long-term trial data set, and this time we have a survival analysis. If you look at a survival analysis, there is a survival benefit. It is not as huge as the PFS benefit that we saw with Solo 2 initial presentation, and it almost reaches 0.05, except for the fact there is a 3.7 behind 0.05. So I would say it's a statistical difference, and the difference between the two is approximately 13 to 14 months, which I believe is a clinically relevant difference in overall survival. If you were to take away the patient who got crossover olaparib, one could argue that this is not the way to analyze, but if you were to take away the patient who got olaparib in placebo, then actually you can see a statistical significant difference, and the difference becomes more clinically meaningful. So I believe Solo 2 also proves the point. It substantially improves progression-free survival, it substantially improves overall survival, has been a practice changer, and now it gives more comfort zone in giving olaparib, because then we can now say that possibly the overall survival is also there. Even if the overall survival is not there, ability to delay next chemotherapy is something which is a quality of life issue. Most of the patients would not want ever to have chemotherapy. They are extremely happy with oral tablet. The ability of olaparib to delay by 20 months the onset of chemotherapy is a substantial benefit. In fact, most of my patients don't want to get off olaparib and they just don't want chemotherapy. We had an updated data on NOVA, but I took up NORA because it has some practice changing things for us. From NOVA and NORA, we know that niraparib in a selected population has shown a significant benefit of PFS, and OS data is still not there. Although this analysis was whether we should start niraparib after 4 cycle and or less than 4 cycle or more than 4 cycle, but we know that in Asian population, mostly Chinese, niraparib shows a significantly prolonged median progression-free survival. If it works in Western population, if it works in Chinese population, then imagine that it possibly works with us also. But most exciting thing is, if you give niraparib, by default olaparib for us, if you give it less than 4 cycle and then give niraparib, or if you give more than 4 cycles and then give niraparib, or let's say PARP inhibitor, there is no difference. So one can actually stop at 4 cycles. They went further and they analyzed if after 4 cycle the patient has achieved complete response, there is no longer benefit of giving 5th cycle or 6th cycle or 7th cycle, and a PARP inhibitor will do as good. On the other hand, if the patient has not achieved a complete response after 4 cycles, there is an additional benefit of giving more chemotherapy and go to 6 or 7 or 8 depending on patient's capability to take the chemotherapy. So it seems the least the amount of disease at the onset of PARP inhibitor, and if it has already reached 0, then no more chemotherapy. But if we can potentially decrease the disease before starting PARP inhibitor, that is the way it should be done, and I think this is something that we should learn for our practice. Gradually, in a selected group of population, chemotherapy is going to be severely challenged by a combination of olaparib and angiogenesis inhibitor. There is a very good synergy between PARP inhibitor and angiogenesis inhibitor. There are at least 3 trials in this regard, some only for platinum sensitive cancer, some for platinum resistant cancer, some for combination. So I'm showing 2 of them. So NRG GY004 trial has been presented before. In a platinum sensitive ovarian cancer, either chemotherapy or olaparib plus idaranib, and it had a combination of both BRCA mutated and non-BRCA mutated population, and it was shown previously that a combination was equivalent to chemotherapy but not superior to chemotherapy. They actually had the guts to prove that it will turn out to be superior to chemotherapy. Although this analysis was their own HRD data set, we will talk about it. So unlike Myriad HRD, they developed their own data set which is called as BRCA HR. They found these percentage of patients who were positive for loss of heterozygosity or HR. Unlike loss of heterozygosity, which is what we get reporting in foundation medicine, and we take it equivalent to HRD, but I don't think we can take it after this data set. HRD is able to split the curve very well prognostically, whereas loss of heterozygosity does not. That was one of the endpoint. But to me, the most important point was this. In an HRR mutant population, which is largely HRD, largely BRCA1, largely BRCA2, in a platinum sensitive population, would we want our patients to be on chemotherapy? Or would we want our patients to be on olaparib? Well, it is very early therapy treatment, not maintenance. Or in fact, I would want my patient to be on this bluish line, olaparib plus cediranib, which is an oral anti-angiogenesis drug. So it seems that in a platinum sensitive population, if we have a BRCA or an HRD, possibly chemotherapy will be passé. Another trial was October, which had a combination of sensitive and resistant disease, either paclitaxel or olaparib plus cediranib. An unfortunate third curve did not come here, but one could see there are a combination of olaparib and cediranib. So a combination of PARP inhibitor and an anti-angiogenesis drug in a resistant population does much better than chemotherapy. Again, in this setting, with the BRCA mutation, it seems that this is going to be the combination of future rather than chemotherapy. There's another trial called Evanova by Dr. Saeed Mirza, which was about niraparib and bevacizumab. Now that we have been using PARP inhibitor, often it comes to our mind if the patient has an exquisite relief sensitive disease with PARP inhibitor and then relapses and then gets into chemotherapy and fortunately goes into a very good response. Should we not be using a PARP inhibitor again? That's a question which patients ask us very regularly. So this is the only randomized trial by Dr. Pujari, in which both BRCA mutant and non-BRCA mutant who had an excellent response to PARP inhibition before, relapsed, got chemotherapy, they were randomized to olaparib with a very good response to chemotherapy or nothing, which was a standard of care. And you could see that the patient who were non-BRCA mutated had a significant number of HRD mutant population. But I think this is the curve which answers the question. Olaparib yielded significant PFS benefit versus placebo in both BRCA mutant and non-BRCA mutant. Look at the hazard ratio. In fact, the hazard ratio is better in non-BRCA mutant across all subgroups. Therefore, there is a select population. Look at here, 20% of population do not have disease at the end of 12 months compared to 0 if they got placebo and even in BRCA mutant population. So it seems excellent BRs, excellent PARP inhibitor responder, a select group of these population would possibly respond again as maintenance therapy well. So that answers this question. Question of multiple relapses, sensitive or relapse case or resistant cases, can you get away with rucaparib? Actually, rucaparib is approved for this. In this aerial 4, where most of the patients were resistant, it seems that in a resistant population, rucaparib monotherapy easily beats chemotherapy, both in efficacy population and ITT population with good duration of response. Coming to the last set of slides, what is the role of immunotherapy in ovarian carcinoma? Unfortunately, immunotherapy has largely been failure alone with PARP inhibitor or with angiogenesis inhibitor, unfortunately. But it seems there is one way of giving immunotherapy. I'm not very sure. It's just that they're trying to find a way for immunotherapy. In OPAL trial, they got everything. They got immunotherapy, they got PARP inhibitor, they got bevacizumab. So that's a very heavy loaded treatment. Most of the patients were not BRCA mutated or HRD, so this trial was not being governed by niraparib. It was niraparib with immuno and bevacizumab in an otherwise PARP not sensitive population. They had an excellent disease control rate. We do not have any information for how long. We all know this cost is exorbitant. In fact, olaparib itself is exorbitant and immunotherapy itself is exorbitant. To have all three together is difficult. So this water plot looks exciting, very costly, too early days. At this point of time, ovarian carcinoma is not an immunosensitive disease. To summarize, no more bevacizumab. In a resistant cases or late cases, in a BRCA mutant population, PARP monotherapy does as good as chemotherapy. We have good data set with SOLO 1 and SOLO 2. Now we have a data of Asian population, Chinese in niraparib. If you have got excellent response after 4 cycle of chemotherapy, don't go to 6th cycle and use maintenance PARP inhibitor. If you have not achieved complete response at 4 cycle, try to achieve complete response if one can, and delay maintenance immunotherapy. Opal is immunotherapy, I'll forget it. There is a lot of data set coming up on anti-angiogenesis and PARP combination. Possibly in future, many of our chemotherapy patients will not be eligible for chemotherapy and they would be treated with PARP inhibitor and anti-angiogenesis drug. Excellent responders to PARP inhibitor can be re-challenged with PARP inhibitor. Now we have a data set to use.